For those of you who don't know CPR, unfamiliar with us, we're a national legal advocacy center. We're based primarily in Massachusetts, and we use litigation, legal strategies, advocacy, and policy to promote the integration and full community participation of people with disabilities and all others who are devalued in today's society. We're dedicated to enforcing and expanding the rights of people with disabilities. And we see ourselves particularly enforcing and expanding the rights of those who are in segregated settings. We work on a state, national, and international level, and we're committed to equality, diversity, and social justice in terms of the main focal points of our work. Our emanating values within our organization are around equality, choice, and integration. And it's really this issue of choice that has led us to be here tonight, and offering choice and making sure that people have the information they need to be able to make informed choices and participate in the decisions that directly impact them. Since the beginning of the pandemic, much of what CPR's work has been about has really shifted. And that shift has really been to address health equity issues for people with disabilities and people from communities of color. This shift in our work happened after we learned that people with disabilities and people from those communities of color were either at the end of the line or not even in line for life-saving ICU treatment and access to ventilators. CPR worked with a large coalition of civil rights groups in Massachusetts and some national groups to get meaningful changes to the Massachusetts crisis standards of care that were explicitly discriminatory in their original form. CPR has also worked closely with the Massachusetts Coalition for Health Equity during this time, and that has really been a great source of learning for us. We have successfully challenged the rules that the state of Massachusetts issued about access to critical care and worked to ensure that people with disabilities and individuals from Black and Brown communities had at least equal access to life-saving care. Our understanding about intersectional issues confronting people with disabilities and individuals from communities of color with respect to the crisis standards of care and health equality has deepened during this period. CPR and our national partners have been involved in filing complaints with the Office of Civil Rights of the U.S. Department of Health and Human Services, challenging crisis standards of care, this access to life-saving treatment in 12 states, and alleged that those states were discriminating against individuals with disabilities and against people from communities of color. More recently, our work has really been dedicated to ensuring that people with disabilities and people from certain high impacted communities not only get prioritized for the vaccine, but that they are provided with the information and the answers to their questions so that they're able to make informed decisions and to have their questions answered and their concerns addressed. So as a result of that, we held a series of listening sessions with different advocacy organizations across Massachusetts, a cross-section of disabilities, some family groups. We held these listening sessions and we asked people directly what their questions were, what things they needed to have answered, what their concerns were. And those sessions were really, we've learned so much, and it was such a privilege to be in conversation with people about those things. As a result of that, we thought that there were many questions that people had in common. They weren't all identical. I should say that we asked the groups that sponsored these and worked with us to set these up to ensure that there was a cross-section of people of color, people from different ethnic and cultural backgrounds at these meetings. So we really had a really rich conversation about what works in certain communities, what doesn't work, who people wanted to hear from, and who they didn't want to hear from, who they trust, who they don't trust. So we then took all that information and did our best to put together a panel to answer your questions. We hope that the event will provide you with many of the answers to your questions. I want to say that we're really thrilled to have so many of you tonight with us, and that CPR is honored to have so many talented speakers tonight who are both committed and really very accomplished in their fields. And I might add, it's kind of delightful that they're all women. Tonight's four speakers each bring a wealth of professional experience, expertise, and commitment to this conversation. They're each in the trenches and combine deep personal and professional experiences in their work on healthcare, disability, and race. So that said, the conversation is going to be a little bit truncated in parts. It's not going to be just question, answer, question, answer. We're going to do this a little differently because some of our speakers have to leave and some of our speakers are coming a little later. So we're going to start tonight. I'd like to introduce Dr. Cheri Blauwet, who is a leader and change agent and who empowers others to reimagine, I've read your blog, their full potential and ability to achieve optimal physical and mental performance. Dr. Blauwet describes herself as a sports medicine physician at Harvard Medical School, a change leader and agent, a Paralympic gold medal winner and winner of multiple international marathons, and finally, but not at all least, a wife and a mom. So Dr. Blauwet's going to be here, make a presentation. She's going to have to leave after her presentation, but has really graciously offered to answer questions that you might have that you don't get a chance to ask her tonight. And in that case, you can send them to us and we'll make sure she gets them and we get the answers back to you. Dr. Blauwet?
Yeah, fantastic. Thank you, Cathy. Really appreciate the opportunity to be here tonight. And many, many thanks to CPR for convening this event and this opportunity for the community to gather to learn more about the vaccine and also just generally health equity as it relates to COVID and the disability community. So as Cathy introduced, I'm a physician. My primary practice is focused on sports medicine. I do also work in the health equity space for our large healthcare system here in Boston, which is the Mass General Brigham system. And I am myself a wheelchair user and person with a spinal cord injury, so have lived experience as well. So I don't have slides for tonight, but I just wanted to provide some comments that I hope are helpful when we think about how to the paradigm and what are some key considerations as it relates to health equity for the disability community around COVID. I'm not an infectious disease expert, and so I'm actually going to comment a little bit less on the vaccine itself, but in general, try to provide overall a health equity framework and how we should think about access to testing, access to vaccine as a rights-based issue for the disability community. So I'll start it off by saying that we know that people with disabilities experience long-term health consequences due to barriers in accessing equitable care. There's a significant impact of systemic ableism and this pervasive bias that really devalues the life of people with disabilities and underestimates our quality of life. There are considerations around inaccessible environments, and that's physical inaccessibility, but also accessibility more broadly defined, right, as it relates to communications and how we communicate. And then there's a profound impact of the social determinants of health as it relates to people with disabilities being able to access equitable health care. There was recently a study, it just came out a couple of weeks ago in the journal Health Affairs that was published by one of my friends and colleagues here in Boston, Dr. Lisa Iazzoni, where they surveyed physicians about their perception of people with disabilities and found some trends that are honestly somewhat concerning and really create a call to action for ongoing work to continue to educate and reduce bias that we know currently exists towards people with disabilities. Some facts and figures from that paper, they noted that a total of 82% of physicians reported that they perceived that individuals with disabilities had a worse quality of life than non-disabled individuals. So clearly, a huge element of bias there. Only 41% of physicians were confident about their ability to provide the same quality of care to patients with disabilities. And only 57% strongly agreed that they would welcome patients with significant disability into their practice. So I bring those figures forward not to paint a doomsday picture, right? Mm-hmm. Or to say that everything's negative, but just to say that there's a reality here that we're working in, where we know there is still a lot of bias and stigma that creates significant challenge for us to be able to provide equitable care more broadly to people with disabilities. Additionally, as it relates to health equity, we know, I know that all of you on this webinar know that disability is intersectional. There's really good statistics from the Centers for Disease Control and Prevention that indicate that 40% of adults over 65 years old have disabilities. I think that's actually probably kind of low. I think it's probably higher. That 25% of African Americans have disabilities, and so on and so forth. So we know that, this is an intersectional issue. It's not just a disability issue or just a race issue or just an age issue. We all have to really work together and come together to create solutions. We talk a lot about the impact of COVID and how a lot of the public health policies have had unintended consequences for the disability community that although these policies are important for reducing community spread, they have created additional challenges for the disability community. For example, policies around social distancing, which are so important for preventing COVID, have created difficulties with individuals who require hands-on care, for example, from PCAs or rehabilitation services, and some communication difficulties for individuals who rely on tactile cues to communicate. We know that stay-at-home orders and isolation have increased the risk of loneliness, mental health challenges, have increased difficulties in obtaining things like medications and durable medical equipment and other essential goods and services. We know that the closure of many outpatient centers has led to challenges related to continuity of care for everything, not just related to COVID, but the typical healthcare services that we all rely on to stay healthy and to live a quality of life. And of course, we know that universal mask policies, although they're so important for reducing community spread, have created challenges for individuals who rely on lip reading and facial cues to communicate. And also, there's generally been a lack of guidance around how we should consider accommodations for face masks for people who can't tolerate them because of the presence of a disability. And that's been a very challenging issue in healthcare environments in general throughout COVID. So what have we done? So I wanted to provide a framework for some of the health equity work that we've done here in Boston that I do think has significant implications related to the vaccine rollout. We've thought about it from the standpoint of three prongs. That is universal access and equitable access at our hospitals and healthcare facilities. The second prong is our community health response. And then the third prong is city, state, and federal advocacy, particularly touching on some of the concepts that Cathy mentioned in her introduction related to things like crisis standards of care, for example. In that first pillar related to universal access, we've been very explicit to ensure that we have access to things like face masks that are transparent to facilitate equitable communication between clinicians and people with disabilities. And that's been a really important tool. Some of the designs are easier to use than others, but something is better than nothing for sure. And we're now working to make sure that those masks are available at all of the vaccination sites, the mass vaccination sites especially, so that when people go to get vaccinated, they have the ability to communicate effectively with the clinician and healthcare providers in that setting. We've done quite a lot of work to refine the COVID policies in our healthcare system to ensure reasonable accommodations and to reflect a disability equity lens. So for example, COVID led to a lot of hospitals having very restrictive visitor policies, which created challenges for individuals with disabilities who may rely on a PCA or a family member, either for hands-on care or to facilitate communication. And we had to do a lot of work to define and educate about the difference between a visitor that's sort of nice to have versus a personal assistant for a person with a disability, which is a right and something that we have to, of course, accommodate in a healthcare environment. And that took a lot of work to say, yes, we have a visitor policy. And yes, because of COVID, our visitor policy is restrictive. Necessarily, you can't be in the hospital and have 8 family members come visit you. But if you are a person with a disability, you have a right to have someone with you in the role of being an essential support person, whether it be a PCA or whether it be a family member who acts in that role. And of course, for people with disabilities, it's your right to define who that is, whether you want it to be a family member or a professional that you work with regularly. So that took quite a bit of work. And I would say it's honestly still a work in progress. It's one of those things that you can define a policy and educate, but you have to do continual education around that. Otherwise, people forget and people still fall through the cracks. We've done quite a lot of work regarding the universal mask policy and creating a flow operationally for how we would manage if an individual can't use a face mask because of their disability. And we've created a list of other accommodations that can be considered that I think has really helped people working in clinics and healthcare settings to understand what some other options are. So things like having the individual travel through a less populated area of the hospital to their destination so that they have less close contact with other people in the environment, even though they can't wear a mask. In having the individual go straight to a clinic room rather than waiting in a busy waiting area. Something that's not difficult to do as long as you can plan ahead and understand that that can be an accommodation in this environment. Thinking about transitioning to virtual care, if that's an option for the individual, and doing a virtual visit instead of an in-person visit. And also guidelines around, how to best assist someone with putting a mask on and taking it off if they have difficulty doing that themselves because of limited range of motion or limited dexterity in their hands. So that's been another process that we've really worked hard to implement.
Cheri, excuse me. People have asked that you speak a little more
Oh,
slowly.
sure.
Okay.
Sorry about that.
Yeah,
It's hard for me to talk and watch the chat. So
Yeah.
thank you, Cathy. Appreciate that. Some of the advocacy-based initiatives that we've been involved in have been involvement in the crisis standards of care revisions here in the state of Massachusetts. Our colleagues at CPR were absolutely critical in helping to advise that process as well. And although where we landed wasn't perfect, it was a lot better and reflected some good compromise between the disability advocacy community and others who were also involved in that process. For example, the removal of comorbidities in terms of the scoring system, removing or shortening the period of time in which one would be assessing something like what we call long-term survival and so on. And I know that's not our focus tonight, so I'm not going to get too in the weeds there, but just want to say that we considered that to be part of the health equity response for COVID. We're also working to consistently raise our voices and be involved in broader health equity conversations at the city and state level. So for example, the city of Boston is now putting together a strategic plan called Health Equity Now. And we're working hard to ensure that considerations of disability equity are brought into that process. And that, again, we're recognizing the intersectional nature of disability with other characteristics that lead to people being underserved in the community. And the last thing I want to mention, and then I'll turn it back to you, Cathy, is one thing we're really pushing for is improvements in collecting data. So, when you think about how we measure how well we're doing in terms of the response to COVID, whether it's, who's getting tested or who's receiving the vaccine, data is very powerful because it helps us to call out where there may be disparities and where there may be inequities in care. And for many years, really for as long as I can remember, disability is often left out of data collection. And that's a real disadvantage because without data, we can say that the response is inequitable and we know that it might be, we can see it happening, but without data, it's a harder argument to make in terms of changing policy. So that's a big push and one that is important here in our community, but also very important at the federal level in terms of the COVID response. So I certainly hope that as this continues to roll out, that we can continue to wave that flag about the importance of data collection in everything that's happening in order to improve services into the future. So I'll pause there and I'll turn it back to you, Cathy. And I can stay for a couple minutes to answer a few questions, and then I do have to run, and I apologize.
Okay. So then we can take a few questions right now. If people have them, please raise your hand. Okay. Can we unmute? I don't know if I can do this. I can't. There's a woman named Sharon.
Yes.
Yeah, good. Sharon, do you want to ask your question? It doesn't seem to be working. Alex or
Sharon, you
I'm
briefly
unmuted,
there
but
you are.
you muted me again.
okay.
Okay, so that was excellent. I am a blind person and I just had my first vaccination, and I didn't have any sense that there was any data being taken about the fact that I had a disability that I was aware of anyway. And my thought about it also was that had I not had a person who could see with me, I would have had a really difficult time at Worcester State University or any site like that, trying to get through the process.
Yeah.
Thank you. Yeah.
Thanks, Sharon. You know, one thing, so you're right, we're not collecting data right now. it's an ongoing advocacy push.
Okay.
So I flag it tonight as something that requires a lot more work. What I would say is that one thing that that we're pushing for is for the state to make more information more readily available, so that you can call in advance if you have a disability and flag that you're coming, so that they can be prepared and provide the adequate assistance. So for you, Sharon, for example, if wayfinding, for example, is a challenge, that you'd be able to call ahead and say, I'm coming, I'll be there at 3 o'clock. You know, could someone meet me by the entrance?
Right. That would be good.
Yeah,
The other
point of contact is
important.
Yeah.
The other thing I just like to say for as people unmute, give them an extra second, because sometimes finding the mute button and the unmute button takes a minute for our host. Okay.
Okay.
So just allow for a little bit of time, because people have to swipe around for it. Okay.
Okay. Yeah. Thanks,
Thank
Sharon.
you. Okay. Thank you.
Cathy, I could take one more and then I'll hop off.
I can't see all of the hands that may be up. Yanni, Alex.
I'm scrolling through looking for hands right now.
There was one, Cheri, that someone asked if you could write or just say the name of the journal you were referencing that study was in.
I actually listed a link in chat, but you
did you? Okay, thank you.
Perfect.
Teresa's raising her hand.
Yeah.
Hello, can you hear me?
Yes.
Hi, I put this question on the chat as well, but my question is, what has led some states to prioritize people with disabilities to access the vaccine and the priority list versus some states that have not done so? And is there anything as a disabled citizen that like we can do to advocate for more efficient and more equitable prioritizing in terms of people with disabilities?
Thanks, Miso. Great question. I think, you know, the way the vaccine rollout has occurred is that there's been some federal coordination, but really most of the coordination has been at the state level. And so states have been allowed to make state-by-state decisions about that, how they prioritize. And you know, I think there's just been in some states probably more advocacy or the right people around the table to push for people with disabilities to be included in the earlier waves of vaccine rollout. A lot of states are still relying on the CDC list of conditions that have been proven in research to put one at higher risk of poor outcomes with COVID. But we know that that leaves out a lot of people with disabilities who we know are likely to be at higher risk, but because of the fact that the research process is a fairly slow process and because of other barriers, maybe there isn't a study to show that they're higher risk, but we know that they probably are. And so really, I think the most important thing to do now is to continue to speak up and to say that we want change to occur, and to write an op-ed or call your congresspeople, and to continue to push for that change. And I'm sure the other panelists will have thoughts on that as well. But it's a time to speak up, I'd say, and to not be quiet about the change that we want to see. Okay, thanks everybody. Thanks, Cathy.
Sorry, thank you. I cannot believe it. Sorry about that.
No problem.
Thank you very much. And I really appreciate you making the time because I know you have another commitment tonight. So thank you. And
Thank you.
we'll be in touch. Bye-bye. I'm sorry that we are not going to have Dr. Blauwet with us to answer more questions, but our next speaker I'd like to introduce is Regina La Rocque. And I do want you, if you want your question specifically directed to Dr. Blauwet, you can put it in the chat and we'll make sure she gets them. Regina is a physician who also has a master's in public health from the Harvard School of Public Health. She was trained in internal medicine and completed a fellowship in infectious diseases. And she works at Mass General and is an associate professor of medicine at Harvard Medical School. She's co-authored a lot of peer-reviewed publications and book chapters. And what I found interesting that I didn't know about her when I was reading about her today is that she's particularly concerned about the impact of climate change on human health and the spread of infectious diseases. So we've had the privilege to work with Dr. La Rocque as part of the Mass Coalition for Health Equity, and really happy that she can be here tonight. So she's going to say a few words and then we're going to do a question answer format, and then we'll stop at some point with the questions that came out of the listening sessions to make sure people get a chance to ask some who are on the phone tonight or with us tonight.
Well, that's great. Cathy, thank you so much for the
Sure.
very kind introduction. And it's really an honor to be here with CPR. I've come to learn about your organization over the last year and am so impressed with the work that you've been doing. So I'm an infectious disease doctor. I take care of patients with infections in the hospital. I'm also a researcher, and I've done research for 20 years on developing better vaccines for illnesses like cholera, particularly. So I have a lot of familiarity with how the process works for developing vaccines. I also have worked for 20 years in the immunization clinic at Mass General, and I've had a lot of experience talking to people who are receiving vaccines. And lastly, I'll share that I have a 14-year-old son who is autistic, and I have some understanding of the concerns of the disability community as well. So I'm here tonight because I want to make myself available to talk and answer questions about the vaccines that are coming out for COVID. I feel like we're at a very important and precarious moment in the pandemic. We do know that the vaccines have brought a new hope for another tool in our toolbox for dealing with the virus, and it's a very hopeful time. But there are concerning things happening with the virus itself. It is changing. There are some new slight changes in the virus that are making it concerning from an epidemiologic perspective. So it's really important right now that we as a country and as a society be doing everything we can to get this virus under control. And I think I know, as all of you do, that it's been a year of tremendous suffering on many levels for many people in different ways. So I mostly want to answer questions. I guess the one thing I'll say to start off with is I do like to let people know a few key things about these vaccines. Number one is that the vaccines that we have available now are the product of many, many years of research and technology development that has been going on for some time. You know, we have known in the infectious disease world that viruses like this would be a concern for the global community and that we needed better ways to make vaccines to respond to viruses like this. You know, we had the outbreak of the original SARS a couple decades ago now, and then MERS, which is a related virus. So it was kind of partly because of that we developed and put into place the ability to make some of the vaccines that we're now seeing come to fruition. And then the other piece that I think is really important for people to understand is that the vaccines that are currently being offered to the public have gone through the exact same regulatory and review process that any vaccine coming out for Americans would go through. They had to meet very specific pre-specified criteria before they could be allowed to be released. And they've been reviewed by many, the data about the vaccines have been reviewed by many panels of physicians and experts from the FDA and the Advisory Committee on Immunization Practices before they were made available. And then we also are doing ongoing surveillance for the millions of people who've been getting the vaccine so that we can know if any unidentified events or not expected events have been occurring. So there is a broad range of mechanisms in place to ensure that the vaccine is as safe as possible before it's being released to the public. So that's just an overarching view I wanted to give before we started. So I'd be very happy to take some questions.
Okay.
Another thing I just want to say is that this is a vaccine that people have to decide that they want to get. Nobody's being forced to take the vaccine, and it's really important for people to be educated, to learn about what it's about, and to get their information from good sources.
I got it.
Okay. Thank you. So the first question was, did people with disabilities and people of color participate in the vaccine trials?
Yeah, so it's a good question. So all of the vaccines that are on the market now have gone through a series of phases of study. The last phase of study is where tens of thousands of volunteers receive the vaccine and are followed very closely mostly for getting really bad COVID and whether the vaccine protects you against that, which of course makes sense. That's what we want to protect people against. And there was a concerted effort as these studies were being developed to be sure that we included as many people from with disabilities of a broad range of ages, of color in the studies, so that the studies represented the population. So the answer to that question is yes, there were representation of people of color and people of different ages in the studies, not children, but adults. Mm-hmm. Now, that being said, when we're talking about studies of tens of thousands of people, it's not going to be the case that a less common medical condition was represented in that study. So we only know what we know from the people who were in the studies, and it doesn't include every condition in the world. So that's why it is very important as the vaccine is rolled out to more and more people, now millions of people, that we have our eyes on this and that we're watching to see if any untoward events arise. And that is ongoing. That is partly how we have identified that allergic reactions can occur with the vaccine through that kind of surveillance.
Another question had to do with the kinds of allergies that might be people should be careful about, or at least it should be on their minds when they're considering whether to take the vaccine, and whether there's certain vaccines that are better than others for people with allergies.
Yeah, so this allergic reaction to the vaccine has arisen as a concern. I will say that even though it has occurred, it is still occurring at relatively rare numbers. I mean, I think as an infectious disease doctor, I give people intravenous antibiotics and other medicines that cause allergies at much higher rates than what we're seeing with these vaccines. So that's just an important thing to keep in mind. But they do occur, and I think we don't fully understand in some instances why they've occurred. Certainly it is a reaction to a component of the vaccine, and most people think it is the fatty material that is stabilizing the mRNA vaccines. So the bottom line is we have implemented now a standard observation period after somebody receives the vaccine to monitor for a severe allergic reaction. And probably anybody who has a personal history of having a severe allergic reaction, you might want to get the vaccine in a more controlled setting, like a hospital or a clinic, and talk to your doctor before having the vaccine.
Okay, thank you. Are the vaccines safe for people with compromised immune systems?
So we do worry about giving some kinds of vaccines to people with compromised immune systems. And there are some vaccines that we simply do not give to people with compromised immune systems. The vaccines that are coming out for COVID are not those type of vaccines. There's no reason to think based on the way they work or the biology of the vaccine that it's a problem for people with compromised immune systems. We do always worry that people whose immune systems are compromised may not have quite as powerful an immune response to a vaccine. That being said, these vaccines have very strong immune responses. And so people who have immune compromising conditions can get these vaccines, and probably should also be high on the list because we worry about them getting COVID also.
Okay, thank you. Next question, are the vaccines safe for people with underlying genetic disorders?
So I guess I would put that in the category of what I mentioned before. We haven't studied these vaccines in particular in people with underlying genetic disorders. I don't have any reason to think there would be a special concern, but I think that, I don't have any special concerns about somebody with an underlying genetic disorder getting these vaccines. One common question that has come up around these vaccines is whether they affect your genes as a human. And I think that's a common question that people have. And the answer to that is they do not. I shared earlier a video, which maybe CPR could send out, that kind of goes over how the biology of the vaccines work, but they don't affect the genetic material of the human who is receiving the vaccine.
Okay, thank you.
I noticed Dr. Martin is here and I just want to say hello.
Okay. What about, what impact will the virus mutations and variants have on the vaccine's efficacy?
Sure, I'll just maybe make a few kind of big picture comments about that issue. So, number one is that this is an RNA virus, this coronavirus, and we know that these types of viruses, they're just sloppy when they make copies of themselves. They're sloppy copiers. And whenever the virus gets into humans, it has an opportunity to make a lot of copies of itself. And in that setting, there's a chance that the virus happens on a change that benefits it in some way. And these types of things happen more often the more people who are infected with COVID. So when we have a lot of COVID in the community circulating, there's just more and more opportunities for the virus to mutate like this, to change. And that, in fact, is what has now happened. We've seen that, all over the world, even in the United States, that with the amount of virus copying itself going on, the virus has happened on some changes that are advantageous to it. And so the pandemic has changed in the course of that time because of this. Now, the vaccines that we have been studying have been studied in that natural setting of what virus is circulating. So the mRNA vaccines that we studied over the summer, we were studying them when a certain viral variant was circulating, the original one, and they were excellent. They had very good protection. Now we've been studying some of the newer vaccines in the setting of these newer variants that have emerged. And we have seen that the vaccines are a little bit less effective against those variants. I think it doesn't really mean that the earlier vaccines are better than the newer vaccines. I think that just reflects what's been going on with the virus. But the bottom line is, regardless of that, the vaccines are still very, very effective at preventing severe COVID, all of the vaccines that we have. And that is good, because that is the main thing that we want to prevent, is people getting sick and hospitalized with COVID. But it's still important for us all to recognize that this is a very powerful foe we are against, this virus. And we as a society need to do everything we can to get the amount of virus replication down, low, 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 so the virus does not have opportunities to happen upon these advantageous changes. So the question was about the variants, and the bottom line is we need to do everything we can to get COVID under control. Nobody is safe from COVID until everybody is safe from COVID, and the vaccines are definitely part of the picture of how we get there.
Thank you. We have a couple of live questions. People have been in a queue, so I'm going to call on first Julie McKinney. Julie, do
Thank
want to-
you.
Sure.
Thanks. I was just wondering if a lot of people, are nervous to get the vaccine because it went through the process so fast. And I know that you said it went through the same exact process as everything else. But so I'm wondering what we can tell people who are worried about that. So to answer the question, what allowed it to be so fast if they've done all of the checks and balances?
Yeah, thank you, Julie. I think that is a really important question that a lot of people ask. So I guess maybe I'll give, 3 things that allowed it to kind of go fast. I mean, one is that we already had the knowledge and the technology for developing these kinds of vaccines in hand before COVID even happened. We had many decades of work on developing these kinds of vaccines ready to go, and that was an advantage going in. A second advantage was that, our government put a lot of resources into this and a lot of people into this. And so normally when something goes through the development of a vaccine, it's slow because things happen in series, one step, then the next step, then the next step. But because of the people power and the money, there was more things happening in parallel. Each step was ready for the next step to happen. So the steps were not stopped, but they were ready to go at each point of the way. Now, another thing that it's unfortunate, but worked to the advantage of allowing the vaccines to become available, was that there was a lot of COVID circulating in the United States over the summer. And that means that the studies were able to happen very quickly. There was a lot of talk in the infectious disease world in the late spring, early summer, when the vaccines were ready to be studied. What are we going to do? We don't have enough people getting COVID. Maybe we need to give people COVID in order to study the vaccines. Well, that was not necessary in the end, because there were enough places with a lot of COVID that we could study how the vaccine worked. So that was just a happenstance thing that enabled this to move along. And then, we were ready to review them and to have the advisory committee on immunization practice. Everybody was lined up. So all of that, I think, contributed. But it was the same process that would happen for any vaccine. And we have to continue to watch how people do as millions of people get the vaccine. If rare, unusual events occur, we definitely have to be doing that work. And, I think as we've all seen, the resources and people power to actually deliver these vaccines and to educate people about these vaccines and to make them accessible, well, we didn't do that work very well. And we're trying to build that ship while we're swimming also.
Thank you so much.
I think what we're going to do now is switch to our next speaker. So Regina, thank you so much. I hope you can stay on for a while. I know you have to leave a little early, but next I would like to, but thank you very much for being here tonight. Next, I'd like to introduce our next speaker, Nassira Nicola. And she is one of the health and disability leads within the Health Equity Division at the Department of Public Health. And she's a very close ally of the disability community. So I wanted to just acknowledge that. She's also the coordinator of the Vaccine Ambassador Program at the Department of Public Health. When we called there to ask for someone to come and speak tonight, she immediately volunteered, for which we really want to thank her. And because I know she's often in the hot seat. And before, I just wanted to also say, before working at DPH, Nassira worked at the Boston Center for Independent Living for 8 years. So she knows a lot of our friends and colleagues and partners in crime. So thank you very much for being here.
Hi. Yeah, and I just wanted to clarify that like the old television commercials go, I'm not just an ally to the community, I'm a member. I am, among other things, a person with multiple disabilities across almost all of the categories that are represented in this room tonight. And I think also relevantly, I have gotten my first shot of the vaccine. So some of what I'm going to be talking about is based a little bit on personal experience as well as experience from work. Another thing I want to say about myself is that the way my brain works, when I get really excited or really tired, I forget normal words and like substitute really big words that no one has heard before. So if I do that, if I use a word that you don't understand, or if I'm talking too quickly, please interrupt me. I won't be offended. That's just something that my brain does sometimes. So I'm going to go kind of through the questions that I was sent in advance from people who participated in the listening sessions that CPR held. And they're grouped into kind of 3 or 4 categories. So I'm going to go by category. So first is, how do I make it? The first category is making appointments. So how do I make an appointment? What if I need assistance in accessing appointments? The web form is not very accessible. What can I do to work around it? You know, we definitely know. So yeah, so the basic process for registering for a vaccine appointment is to go on the Massachusetts COVID vaccine finder website and enter your information in and keep clicking refresh until you get an appointment. It is a really frustrating process for people whose disabilities are made worse by stress. It can be a dangerous process. This is a thing we know and that we're constantly working to improve. So some of the workarounds for it, which will not necessarily get you a vaccine faster, but might make the process less terrible. If you are unable to use the website because of your disability and you're currently eligible, you can call 211 and talk to someone on the phone and have them do the website part of things for you. You can, a lot of people who are covered by Mass Health, which for out-of-staters is our state Medicaid program, should be getting outreach from, if you're in a managed care organization especially, should be getting outreach from your care team, letting you know when you're eligible. And there is a lot of vaccination work that's actually happening through the health plans. If you have the kind of relationship with your care manager in your health plan where you can actually just contact them and ask them questions, they're a good place to check with to see kind of where you are in the line and what the plans are for getting you vaccinated. So I will tell you how I got my appointment, which is I have a very dear friend who has a lot of time on his hands and likes solving problems for other people. And he actually sat online and filled out the forms for me and clicked refresh while I was at work all day, and finally got me an appointment and got my partner an appointment. That is not the way a state government program should necessarily work, but I will say it's effective. And so if you have people like that in your own life who can do that for you, like, I am not about to tell you not to do it. Again, we are working on making every part of this process easier to access, but if you have your own solutions in the meantime, you should absolutely go with those solutions.
Can I just interrupt? Someone told us that the governor's office has someone who just answers the phone and takes complaints and gets people appointments. Have you heard that?
I've heard rumors of that. I suspect that the more people call the governor's office, the harder it will be for that person to keep doing that thing.
Yeah.
Like I suspect they're doing that because they're not getting a ton of calls yet. That said, if that becomes a problem in the governor's office, it's possible they may dedicate more staff to doing that.
Mm-hmm.
So again, if you have a workaround that is working for you, use it.
Okay.
So the next question is, how do I show eligibility? And I will say one thing I'm actually proud of in the way we've rolled out the vaccine is that the way you show eligibility for the vaccine is you fill out a form that says you're eligible. And it gives you a list of what the criteria are, like what the specific categories of people who are eligible right now are. You say, yes, I'm in one of these categories. You sign it. You promise the state of Massachusetts you're telling the truth, and you're eligible for the vaccine. A lot of people are worried about, like, well, what if people cheat on this? And like, yeah, it's possible. If it is a lot easier to pretend to be a healthcare worker and get vaccinated in phase 1 than it is to pretend to be a person with a disability and to have to like wait till phase 2. I'm not super worried about fakers. What I am worried about is people who don't have a consistent, useful relationship with the medical system, who can't get their medical records in order to prove to someone that they're eligible for the vaccine. So we've made the choice to not make it harder than it needs to be for people to prove that they're eligible. So yeah, it's on the honor system. Please don't make us regret it. The next question is, what are the comorbidities that qualify me for phase 2? Again, not a perfect list. But the list as it stands is cancer, chronic kidney disease, COPD, which is a particular lung disorder, Down syndrome, some heart conditions, if you have a weakened immune system because you had an organ transplant, if you have a BMI, that's a body mass index of over 30, pregnancy, sickle cell, if you are a current or previous smoker, type 2 diabetes, and moderate to severe asthma. So right now, in the phase that we're in, you need to have 2 things from that list in order to be eligible based on your comorbidities. I encourage people with disabilities to be very, very familiar of what counts in each of these lists. Like chronic kidney disease covers a lot of things. Heart conditions covers a lot of different things. It's possible you are eligible and didn't realize it. But it's also possible, and it is a thing that I hear constantly, that you have a disability that is less common than some of these conditions. And because we just don't have numbers on how likely people with very rare disabilities are to get COVID and to get very sick from COVID, they're not included on the CDC's list. And actually, until I looked into the heart conditions on the list, I wasn't eligible either. So I super get that. I have a pretty rare genetic condition that causes most of my disabilities, and I was very worried. So definitely look into that. The next question is, how do I have a choice of which vaccine I receive? And the answer is kind of. Different sites offer different vaccines. So if you're really set on having a particular type of vaccine, you can make sure to check what vaccine each place is offering and only sign up for a vaccine at the place that offers the shot that you want. I will say, under almost all cases, there is not likely to be a difference in the effect on the vaccine, the effect of the vaccine on you. And so the best vaccine to get is the one you can get. Okay. I feel like I'm doing a lot of talking. Next.
Can I just ask, and maybe this is a question for Regina, if you don't know, if you get like one of the vaccines that have a 2-dose, system, can you get one vaccine for the first shot and a second the different vaccine for the second shot? You need to get the same one for both.
You need to get the same shot both times.
Okay.
There's actually a question later in my list for when do you make your second vaccine appointment? And the answer to that is you should be making it at the site, like while you get your first vaccine or right after you get your first vaccine. And doing it that way makes sure that you get the right vaccine for your second shot.
Thanks.
Okay, what the experience is like. So what should I do before and after getting the vaccine? I would make sure you're rested. If you have someplace to be the next day, like maybe plan not to go there if that's possible. So if you have work or a day program or something that is expecting to see you the next day, see if you can call out if that's possible. You might feel anywhere from totally fine, maybe a little sore, to really, really tired and headachy. And so it's good to kind of take that step if you're able to. Otherwise, it's pretty much like preparing to get any other shot. It's not all that different. What happens at the appointment? So how long will I wait in line? They usually tell you at this point to show up like based on the size of the place that you're getting it at, somewhere between 5 and 15 minutes early. And again, they'll tell you exactly what time and how far in advance to show up. So you'll get there. They don't want people standing in line for a long time, A, because who wants to stand in line for a long time? And B, the more they can keep you away from other people, the better. So they're really trying to move people through on a very scheduled basis so that they don't have a lot of people standing around together for a long time. Mm-hmm. Can my support person come with me? Yes. If anyone hassles you about it, it is official policy that they are allowed to accompany you. Feel free to say it is DPH policy that my support person be allowed to accompany me. Those exact words. And you can even say as a reasonable accommodation for my disability. Can I bring my headphones and sensory items? Yes. Particularly if you don't like being in like a big convention center with echoes and things. Definitely bring your headphones. I'm laughing because someone who I can see on camera has a service dog named Echo, and she just made a face at me, and that's why I'm laughing. So yeah, definitely bring whatever will make you feel comfortable in that space. I brought my headphones and was listening to an audiobook and had my knitting with me, because everyone who knows me in person knows that my knitting is my fidget toy. Who will give me the vaccine? Usually it will be like a doctor or a nurse or an EMT, like a paramedic or someone. In all cases, it'll be someone who's been trained on how to do it properly. There's not a question about this, but it's worth, oh yeah?
I thought you had finished. I apologize. I didn't mean to interrupt you. I think we're gonna have to switch to Dr. Martin in just a minute. So
yeah, absolutely. Tell them if you can't get the vaccine in your arm and they'll do it somewhere else, is what I was about to say. In-home vaccination is starting to roll out soon. Again, that'll be handled either by your local Board of Health or by your healthcare plan. So contact one or the other to find out which. And then there's some questions on equity and where the sites are and why they're placed there. And I'm happy to discuss that afterwards. But I don't want to steal any more time from Dr. Martin, and it's possible it may get answered before we get to the end.
Okay, I just froze, but I think I'm okay for the moment. So I'm going to take advantage of being able to introduce. First of all, I want to say thank you very much, and we'll hopefully have some questions, time for questions at the end. Like to introduce Dr. Atyia Martin, who is a certified emergency manager and the CEO and founder of All ACEs Incorporated. She has 20 years of experience applying the principles of racial equity and social justice during her career in resilience, emergency management, public health, and intelligence. Dr. Martin is a member of the Boston Black COVID-19 Coalition, and she's recently written a book called We Are the Question and the Answer, Break the Collective Habit of Racism and Build Resilience for Racial Equity in Ourselves and Our Organizations, which I'm going to order tonight. So anyway, thank you very much for being here, and take it away.
Thank you very much. So first of all, good evening, everyone. It is such a pleasure to be in your space with you. Thank you for all that you all do to support each other and stay informed of all the different things that affect our lives. It's one of the things that I'm going to talk about tonight, which is our power to take action, to influence. And so I guess the most important thing to know about me for this conversation is, number one, that my husband and I have too many children. We have 5 kids, 2 still at home. And the reason that's been an important part of my life, in addition to all of the work it takes, is that's where I've done most of my learning around what racism is, how it works, how it impacts real people. How do you work to prepare people to go out into the world and hold on to themselves, stay who they are while they are in a world that's constantly trying to make you something that the world wants you to be and not who you are. And so for me, that kind of informs everything that I do. It's the biggest education beyond all of the nerdy degrees that I have and all that stuff. It is really my foundation of my education. And so all of that to say the work that I do with what's called the Black Boston COVID-19 Coalition is really something I do through my nonprofit, Next Leadership Development. And that work has been going on for a year now. We're almost at our 1-year anniversary as an organization. We are a coalition, which means we have over 200 people and organizations who have come together to say that we know that this pandemic is going to disproportionately impact people of color, especially Black people, because we know that racism is a real thing. And it influences how we make decisions, and it influences who we think should get certain resources and how those resources happen. So we came together in order to try to get ahead of some of the things that we could see coming. And not just from our own individual experiences, myself included, but also as a nerd who spent a lot of time reading a lot of stuff about the research around what happens when we have disasters. We know that people of color, people with disabilities, people who are struggling financially, people who are outside of what someone put in the chat, you know, there's no such thing as normal, right? But we know that in the way that we sometimes put programs and policies and rules together in a way that that are done for a normal population without any consideration for all of the different needs that people have. So this is why the Black Boston COVID-19 Coalition came together, is to say, well, we want to make sure that we are inserting ourselves in every part of this process that's happening with the COVID-19 response to advocate for Black people in the city of Boston. And we work very closely with other organizations in the city, different groups that represent different constituencies, from people with disabilities all the way to other races and ethnicities, in order to make sure that we're also maximizing our power together, and that in recognition that we have some unique needs too. That said, the interesting thing about the city of Boston is that if you look at a map of where most people of color live in the city, and then you look at a map of where you see the highest number of people with disabilities, it overlaps on top of each other. So that says a couple of things. It says that number one, there are high numbers of people of color with disabilities, but also there are people with disabilities who are not people of color, who are being placed in communities of color, mostly through housing developments. So, and that means that there is a shared struggle in terms of what it means for people with disabilities to be left out of different decisions that get made, and that in the Black community in particular, there's a higher number of people with disabilities. And so when you start to think about all of those pieces, and that means we have to work extra hard in order to advocate for the range of needs that people have in our community. And it means that we have the opportunity to not just advocate, but to support one another and fill in some of the gaps while we are doing the advocacy. What I mean by that is people have needs today. People are hungry. People are struggling financially. People feel left behind, like no one cares about them. And so part of our work is really about how do we make sure that we are filling in some of those gaps. And so for most of the time as the Black Boston COVID-19 Coalition, we've also been filling in many of those gaps to the best of our ability with the resources that we have. So doing wellness checks on seniors and people with disabilities, offering gift cards and resources to those households, making sure people know where they can get tested at the time and now where they can get vaccinated. And if they need to get a vaccine and they're within the city, we can help them with their appointments, which gets to one of the things that is an example of what happens when people come together to be able to take care of Dr. La Rocque. Excuse me. What happens when people come together to advocate? So when the state first opened up mass vaccination sites, they were in places that were not near where high numbers of people of color live. And so if you didn't have a car, you couldn't get there. And the part of the challenge is when the decisions were made, many of them weren't made in kind of a strategic way, at least from the outside looking in, right? And so if you look at a map and you see where the concentrations of needs are versus where vaccinations were happening. And so as part of the strategy, we advocated with the city at the time to say, hey, we're having a hard time communicating with the state, but maybe, you know, we can advocate with you to get a site closer to where people of color live. And the first site that the city identified was the Reggie Lewis Center in Roxbury. So we did a walkthrough with them to make sure that it was a place that, well, not a place, but that they understood how they were going to lay it out We were concerned about people with disabilities. We were concerned about people who spoke different languages, who's going to do the translation for the materials, who's going to be interpreting for people when they get there, and not just interpret it and including ASL. And so really kind of questioning what was the process going to be so that we can be thinking about priority populations up front. That's what I call all of us folks who are kind of left out of the usual thinking of this work, because when we plan up front for the needs, for all the different needs that people have, then it means that it's more likely going to accommodate almost everyone from the beginning, as opposed to starting from a place of planning and not making those considerations and then having to do all of these add-ons after the fact. So focusing on people who have the most unique needs and situations actually helps everyone to have a better experience, because when things are in plain language, that helps everyone. And it's easy to read, that helps everyone. When you get materials in languages that you understand, that's helpful to everyone, so that we can all have a good experience when we show up to get access to the resources that are supposed to be there for us. So for the Black Boston COVID-19 Coalition, that was the thinking in partnering. Long story short, long story longer, I should say, because I've been talking for a little while now, is that we ended up partnering with the city during the time that the city ran the Reggie Lewis Center as a site, while they waited for the state contractor to be able to set up the site. So we worked with the city on making sure that community members got access to those appointments. And then when the state contractor took over, we met with them immediately before they even went. As soon as they were announced, we reached out to them. We had meetings, and we've been meeting with them all the time ever since, in order to make sure that the process worked for the community, that what we learned from the people who showed up at the vaccination site from when the city ran it was a part of how they thought about the process for now that the state contractor was going to be coming in and running the site, and building on top of that knowledge, as opposed to what they wanted to do, which is come in with with what they were doing at Fenway and what they were doing at Gillette Stadium, right? And we knew that wasn't going to work. And people were already struggling with those other sites anyways. And so this really was a best practice or potential model, I should say, in terms of community partnering with, in this case, the contractor that the state hired, to be able to work through some of the issues up front. And what I will say is that it was hard. It took a lot of time and a lot of energy and effort that people did not get paid for, but it was for the community. And those of us who have the ability to make those kind of sacrifices on behalf of those who cannot have to do that. And so it's part of our responsibility. I personally felt like it was part of my responsibility to do that. And so fast forward to now, and we're still continuing to help people get vaccinated. We hosted a Black History Month event on February 27th and 28th. And we helped 1,600 people get vaccinated at the Reggie Lewis site. And so that's kind of one of the big numbers that a lot of folks talk about, but we had been helping people to get their appointments before then, and we continue to help people to get their appointments. I'll put in the chat the link if you're in Boston and you want to sign up through the Black Boston COVID-19 Coalition. I'll put that link in the chat for you so that you have access to that. And one of the biggest lessons that I learned from this process, as much as I have learned over my life, going through this process with the community and working with folks to advocate, really has been a blessing in disguise, even though it's a lot of work. And even though I have a lot of things that I'm juggling right now in my life, I have learned a lot about what happens when we come together as community to help each other, to advocate, to be consistent and persistent. And in the disability community, there's a saying, nothing about us without us, right? And so being able to make sure that folks know that we're committed to really doing this work, and that we won't tolerate people having conversations and making decisions about us without us. And that should be for everyone in our communities, especially those folks who get left behind, who are underestimated and marginalized in our society. So I'm going to stop there because I've been talking a little long, but I hope that gives you some information about our power that we have. I hope that gives you some information about some of the opportunities we have to work together. And I'll also put in the chat for folks who are in the Boston area a link to the Black Boston COVID-19 Coalition, so that you can sign up if you're still trying to get your vaccination appointment. So thank you, Cathy.
No, thank you very much. We can open it up to questions. We still have at least 9 minutes. I would like to just call on Cheryl Grossman's had her hand up for quite some time. So Cheryl, I'm not sure if your question was for either Dr. Martin or Nassira, but if so, please ask it.
Thank you. This is Cheryl. I'm sorry. It was actually for Regina, and we seem to have lost her. I had a couple of technical questions. It might be helpful for Dr. Martin to hear this as well. For those who have significant immune issues, one of the difficulties that we've had over time, and was heightened because of COVID, was if you don't include us in the clinical trials for vaccines, we don't have any data on the back end as to how vaccines specifically will affect us. And so I guess my question in the intersectional space is, if, it's really hard when AHIP comes out and says, oh, well, maybe people with these certain conditions shouldn't get it because we just don't have enough data, so maybe they shouldn't be highly prioritized. Well, that's always going to be the answer if you don't ever include us in the studies. And you don't include us in the studies because you want good data, you want a product that works, and you want to make money off of the product. There's a chicken and the egg here. So my question was, when can we expect this to move along with society and change so that we can be at that table, nothing about us without us? And I guess my second question is a little bit technical, probably for Regina, but for those of us who don't have the ability to create antibodies and are dependent on immunoglobulins, what's the time frame for the research and development of that product? We do know about monoclonal antibodies. We are doing convalescent plasma, so we know we have the technology there, but what's the time frame to get it into a product that this specific group can actually use it?
Cheryl, we'll get those questions to Regina, and hopefully we can get answers back for you.
And what I will quickly say for clarification, Regina is a doctor of bodies. I'm a doctor of books. So,
and I am a doctor of nothing.
And Jason Glenn, you had a question for some time.
Actually, I don't have a question. I have a comment. So I'm from Indianapolis, and I'm thankful that you guys let me be here tonight. Sure. I just want to tell you guys, congratulations. You're doing a much better job than we are. So send us whatever you guys are doing is, please give us all your tips because we need help.
That's good to hear. Not because I hope that Indiana does poorly, but because it's really easy to see from this level all of the flaws that are still in our system, and there are many. And so it's good to hear from someone with a little bit more perspective.
Are there other questions? Chris? Chris, you're muted.
Wendy
Yep.
has a hand up.
Yeah,
No,
Monique Gerard has her hand up. I can go after Monique.
Okay, Monique. Can't even see Monique.
Sorry about that. Yeah, I had my hand up for a long time. It was for the other doctors, but also for Narissa. I've got my vaccination, the first one. I'll be going probably next week for the second one. And I take care of family members. I am also physically disabled myself. And I got the vaccination, which I was grateful for. My husband also got his because him and I still are like caregivers as well. And we take care of an aunt and uncle that has special needs. And as you see, there's two Moniques, is my uncle right there. He has a pacemaker and he has other issues. When he was born, everything was on the wrong side and they did major surgery to put everything back on the right side. To make the long story short, these lists are unbelievable and you're telling us to go to 211. That is a joke. I've been on it for almost 3 days for 6 hours.
Yeah.
And there's nobody answering those phones. And half the time they just hang up on you and they just drop you. And I don't know what or where, we can get something. We're from Worcester. Everything's Boston. I'd love to go to Boston. When I grew up, I was going to Tufts. But is there anything around us, like around Worcester Central or anywhere? Because I got mine at CVS and I really don't trust a lot of people. I don't trust them like even give me a needle because I wasn't sure if they're just a pharmacist or what they are. But the lady that actually took me in, I guess she was from a medical field, but still I don't trust. But anyways, if it's not an MD or anybody like that or an RN, I mean, how do we know we're getting the right dosage? How do we know we're getting the right medications? And second of all, what's the difference between the one Johnson & Johnson and what's the difference of getting the ones that we're getting now?
Okay, I'm going to speak really fast because my computer is going to restart in 2 minutes and I cannot figure out how to stop that from happening. With respect to the difference between the vaccines, the Johnson & Johnson is a 1-dose vaccine. The other two are 2-dose vaccines. There's mostly no useful difference between them aside from that, unless you have an allergy to something that's like specifically in one or the other of the vaccines. I know, right? Windows. And so if you go to the mass.gov COVID-19 vaccine website, you can find the ingredients list for each of the vaccines and make sure there's nothing specific in any of them that you're allergic to. But for most people in most cases, they're pretty interchangeable. So take whichever vaccine you can get.
Yeah, I had the first vaccine and thank God I was blessed I didn't get no reactions. But my poor husband, his allergies was up for like 24 hours. And then I have a father-in-law who's elderly who should be getting the test and the vaccine. And he's afraid to because he just found out that his friend got it for like 3 weeks of allergies, really bad.
Yeah,
so.
the flip side to that is getting COVID is worse, which is a really kind of quick answer. The other question about the reservations, I will take your comment about the 211 line back to the people who are staffing 211. But also, yeah, the more people get their vaccines, the more spaces will be available because the same people won't be, snagging your appointment in line every time. 1 million people became newly eligible for the vaccine all at the same time in the last round. There are 110,000 doses that are shipped to Massachusetts every week. And so unfortunately, because I'm not a math person, but this is a math problem. Like we just don't have the vaccines yet for everybody to get them quickly.
So why isn't our physicians giving it out so that way we can make appointments and make sure that we have it? Oops, she died out.
Oh, she's gone. That's one way to end. I know there are a lot of hands up and it's now just Dr. Martin. So
Well, I actually could follow up with Dr. Martin is a leader of, earlier I heard talk about what the list of comorbidities are. And I know the Disability Policy Consortium and others of us are advocating for expanding that list to include all of the CDC's comorbidities, to also include people with spinal cord injuries, multiple sclerosis, developmental intellectual disabilities, people who have PCAs who work in their homes, anyone with mechanical ventilation, and also, so we really need to expand that list, and we hope people will do that, as well as to support the Vaccine Equity Now Coalition's demand for equitable distribution. And I'm not sure if I missed a bit of what's gone on, but I'm not sure if people have, Dr. Martin, if you've put that or anyone's put that in the chat, how people can sign that petition and join that work. When, things, I think, as Dr. Martin was saying, when something that helps one group will help all of our everyone. And we think about like curb cuts, think about larger print, all of these things, subtitling, and in this regard, making understanding what we need for equitable distribution for the most impacted communities and to expand access for people with disabilities will help us all, but only if we fight like, thanks everyone.
thank you. I want to thank everyone so much for joining us tonight, and Dr. Martin for hanging in there as the last woman in the queue.
I did manage to sign back in from another device, so if people need me, I'm here.
Oh, good.
Okay, so I do want to say thank you. Please, Alex put his name in the chat. We'll be sending out evaluations for everyone. There'll be a way to communicate back with us. So we want to hear what you think about the presentations tonight, what else you feel you need to know that you don't have answers to, and we'll try to get those answers for you. So on behalf of everyone at CPR, and all of the great speakers, I just want to say thank you so much, and we'll be in touch.